Good afternoon and welcome to the Alabama Public Health Training Network. We are going to talk today about our updated back-to-school toolkit, and we're delighted to have a very distinguished panel with us. We have Dr. Karen Landers, Dr. Mary McIntyre, and Dr. Scott Harris. I just want you all to also know that this is a new updated toolkit. It's purple. And please check out the web address that's being shown and download this because we have made significant changes to the toolkit in response to the schools being in session the last 2 to 3 weeks. I'd like to introduce a special guest right now. Dr. Mackey, our State Superintendent of Schools, has joined us, and he would like to say a couple of words. Thank you, Dr. Mackey.
Thank you very much. Well, it's good to be here this afternoon. I want to say just especially thank you for the opportunity to be here. But most of all, thank you for these folks, the panelists today, and the work they've done. So Dr. McIntyre, Dr. Landers, and Dr. Harris have all been super partners. They have answered questions for us. They've answered questions in the evenings and in the early mornings and on the weekends, and they continue to do that. As Carolyn said just a minute ago, they've done an updated toolkit, and I appreciate you changing the color so we don't get these confused. But again, we are living through a time when things are changing weekly and sometimes daily. And so we need a living document, and they've been wonderful at Public Health to work with us and to make sure that we have the most up-to-date information. To all of our school folks out there, our school nurses, our school administrators, superintendents, and principals, and others who are watching today, I want to say a big thank you for your patience, for your questions, and for your helping us think through these things. At the Department of Education, what we are focusing on, what we want to focus on, and that's, of course, instruction and academics. And that, even in this year, is very challenging. We're having to do remote academics on a level we've never done before. We're having to do in-person academics in a way we've never done it before. And every day, we're meeting new challenges with those academic and instructional challenges. We would not be able to even get through this year if we were not able to kind of break up the responsibilities. And that's where my colleagues here, again, Dr. Harris and Dr. Landers and Dr. McIntyre and the other folks at Public Health have come in to be such good supporting partners in taking over that medical advice. So we don't have to worry about that. Now, I get medical questions every day, and fortunately, I'm able to shift those over to our partners here at Public Health, who are giving us guidance about how to keep our children safe. And my last comment is just on that. As we go through this very difficult and challenging year, the most important thing to everybody on this panel and everybody in our schools and everybody in our department and everybody at the Department of Public Health is to keep our children healthy and safe. Healthy and safe first, academically strong and instructionally sound second, but we plan to do all of that. And at the end of this year, we're going to look back and say we've learned a lot, we've met challenges head on, we have answered questions, and we'll all be stronger for it in the end. I'm sure this will not be our last webinar together, but certainly appreciate the opportunity today to say thank you for the work you do to the Alabama Department of Public Health.
Thank you so much, Dr. Mackey. And I wanted to introduce Dr. Scott Harris, and he will take us and start us off. Thank you.
Sure. Thank you, Carolyn, and good afternoon, everyone. Thank you for joining us. We appreciate Dr. Mackey joining us today as well as all of you who are joining via satellite. It's very good to speak with you again. I appreciated the conversation we were able to have last week with many of you. And again, as Dr. Mackey said, we really are living in extraordinary times. None of us have ever quite been through a situation such as this before, and we're all, I think, trying to do the best we can with the information we have and make good decisions about issues about which no one really has the right answers right now. And so it is a very difficult time, and I just want to thank each of you for the great work that you are doing. It is very challenging. Your jobs are very challenging right now. As I think I mentioned to you last week, I have my own grandchildren who are public school students here in Alabama, and I have a very personal connection to many of the issues that you all are grappling with every single day, and I'm just grateful to have men and women who are dedicated to our children who are in a position to make those decisions. And I want to assure you that at Public Health, we want to be your partner. We want to be here to help you in every way that we can. And so, again, we're happy to have you today, and hopefully we'll go a long way towards answering many of the questions that you have today. We certainly have heard a lot from many of you since we rolled out our toolkit a couple of weeks ago. We've gotten many good responses on that, but also many comments for how we could do that better. And I want you to know that we have heard you. This is a living document. This is something that we will continue to develop as we move along and as we learn more. Now that some schools have been open for a couple of weeks, we certainly recognize that we need to issue some clarity on certain things, and hopefully we have done that for you today. But I want to take just a minute just to read through the objectives that we have and tell you the things that we're going to cover today. Number one, we plan to review the first school openings and give an update on where we currently stand with COVID-19. We will review the core COVID-19 principles. We will review the new COVID-19 screening tool and decision tree, which you can see on page 11 and 12 of your toolkit. We will review with you what is a close contact and how should schools address close contacts. We'll do some case studies for you to give you some examples of situations that you're likely to encounter. We'll discuss how to report positive and suspected cases to ADPH using the ADPH report card. We'll help you to understand the guidelines for isolation and for self-quarantine. And then finally, we'll take general questions as well for things that you might like to ask us. You know, in public health, we have long been used to dealing with diseases that get reported to us and doing investigations of those. And depending on the disease, we may do contact tracing as well. And that duty stays the same for public health. We continue to do that with COVID-19. What's different at this time is simply the sheer scale of the disease epidemic that we're dealing with. In a normal year, we might have a couple of thousand outbreaks or notifiable conditions all around the state over the course of a year that we look into. And with COVID-19 so far, we've had more than 110,000 cases just in the past 5 months. So this is just far off the scale of anything we have ever attempted to do before in public health. And so for that reason, that's why it's so important for us to bring you on board with us to help us with the idea of identifying contacts. We'll spend a good bit of time about that today, but you all in schools play a role that's different really than the role we're used to seeing with our partners in public health. We have guidelines that by and large have been consistent for several months, and many businesses and churches and other organizations have had to think through these types of things for a few months. But for you all in school, it's all sort of coming up all at one time. And so we know hundreds of schools, or over 1,000 schools, or over 100 school systems that are all sort of roughly the same time having to navigate these waters, and we'll do our best to help you get through that. I just wanted to mention a few changes to the toolkit that we'll see. First of all, on page 4, you'll see that we've updated some major and minor symptoms, and Dr. McIntyre is going to discuss that for you shortly. We had a lot of feedback about what symptoms needed to be considered for the possibility of COVID-19, and when do kids need to be sent home if they're in contact with someone with certain symptoms. And I think by stratifying those symptoms in terms of major and minor symptoms, that'll make it somewhat easier for us to do, so that we don't end up in a situation where an entire classroom or classrooms get sent home for someone with a single minor symptom. You'll notice on page 9 and 10 that there's no need to update the seating and bus charts and upload those to the ADPH report card. We certainly hope you will continue to keep those records. Those are going to be very helpful and useful in determining contacts, but that's not something that you will have to upload to ADPH. We have some additional forms on page 11 and 14, including some algorithms for deciding who needs to be referred for medical care and who needs to be sent home as a close contact. We also have some informational sheets that can go home with parents as well to give them information when their child has been identified as a potential case or as a contact. We've updated page 17 as well, if you will take a look at that, and we'll discuss that shortly. On the next slide, you'll see that on page 24, we will have provisional quarantine and isolation guidance, a resource that will be released next week with a new Safer at Home order. As you're probably aware, the current Safer at Home order from Governor Ivey expires a week from today on the last day of August, and it is expected that she'll be addressing that a little bit later this week about any potential extensions on that. Finally, on page 26, we have updated the report card that's used to report cases or potential cases or contacts. Only those COVID-19 major symptoms and close contacts need to be reported, and we'll go over that in a little more detail soon as well. So that's all I had by way of introduction. We have a lot of interesting information to get through for the rest of the day, and we'll all be around for questions later on. So at this time, I'm going to turn the program over to Dr. Mary McIntyre.
Good afternoon, everyone. I'm going to cover some specific areas, turn it over to Karen, and then come back. Specifically, we wanted to talk about the major and the minor symptoms. In the toolkit is on page 4, where you can actually see the diagram that talks about the major symptoms and the minor symptoms. And this is coming from some of the stuff that we heard initially. We actually identified that there were really concerns about the number of symptoms and the report card being completed for so many children, because a lot of those minor symptoms that consist of like the runny nose, the congestion, we all know those are things, sore throat, that children get, especially when they first get back into school. They have a tendency to have more of those. And so these are symptoms that we still need you to pay attention to, because anything that you would have sent a child home for prior to COVID-19, like diarrhea, fever, nausea and vomiting, you still need to do that. You just don't need to send home the people in that class that are close contacts as part of that. Now, with the major symptoms, which consist of new cough, and I was asked to define new cough, new loss of taste or smell, or shortness of breath or difficulty breathing. Why did we identify these as major symptoms? The CDC does that as part of their case definition. And a new cough is somebody, let's say that a person has asthma, or they've got allergies history, and they have a cough off and on, just like I do. I have asthma. Well, what happens is that isn't really a new cough unless it's really different from what they normally have, much more severe from what they normally have. It is a new cough. The same thing goes for the loss of taste or smell. There are some conditions that cause issues with it where it's chronic, but if, let's say that they were fine last week and then this week they no longer have the ability to taste or smell, that's a new onset for that, and it's included as the major symptom and needs to be actually a report card completed when you send that child home. And any close contacts for that child or that teacher also need to be sent home. So hopefully that makes that part of it clear. I'm going to cover mitigation, and I'm fighting with the mask, y'all. I got 2 on. I don't know why I did that, but I did. So I have a double mask on, y'all. So I may have to take one off, but I'm going to try to go with, hold on. So I'm going to try to go with one and leave just the one on so you can hear me. So what are the key principles that you all need to be following when it comes down to with social distancing? And it is extremely important that we follow the mitigation approaches that are outlined in your book, and that's actually covered on these pages 5, 6, and 7 within the toolkit. So it is extremely important to think of these components. I call them pieces of a puzzle. A piece of a puzzle, the more I put them together, the clearer the picture becomes. So If I have pieces missing, I don't get the whole picture. It's not really that clear. I might be able to say, hey, I think this is a horse, but I really don't know that until I get the parts together. This is what I think of with all of those approaches, and I call them also pieces of the toolkit itself to make a difference. If you do social distancing, that's great. But when you start adding those pieces in, when I add the face covering, I add the face shields on top, especially if I'm high risk. When I do and make sure that I have the ability to make sure that these children and the teachers are frequently washing their hands and also using hand sanitizer throughout the day. When I make sure that there's cleaning going on in the hallways, in the cafeteria, within the classrooms, especially if there are any changes in between, that's happening before and after. They're all pieces and components of the puzzle and pieces of the toolkit. So one of them at any time works pretty good, but let's say I get 1/10 of an idea of what that picture looks like because of what I'm doing. As I put more of them together, I get a better idea of exactly what is happening. When I combine them all, I've got the total picture. The same thing happens when I can combine all of the mitigation strategies and I use them all. I get a higher risk of being able to reduce the risk and the transmission of infection. So if I do one of them, that's better than doing nothing at all. But if I really want to get the biggest results and the biggest bang for what I'm doing, I'm going to put them all together, which is why we recommend not just doing one of them, but staying at 6 feet or more distance. And that's just if we're doing regular stuff like talking, not singing. Guess what? When you start adding in other things that push out more of the viral particles potentially, you need to widen that distance. It needs to go further than 6 feet. So let's say we have a situation where there's a choir. Guess what? 6 feet is not sufficient. We actually made a recommendation within our church with the choir that they not only decrease the numbers, because we also have to deal with the number of people, but also we widen the distance to 12 to 15 feet apart because they are singing, and that pushes out more of that virus. So that's why this is so important. Meals. When it comes down to mealtime, in order for a child to eat, they have to take the mask off, the face covering. Okay? So in doing that, they expose themselves and others. And if we don't continue to make sure there's social distancing between them, then that mealtime becomes an opportunity for transmission and infection to spread. Because I have not seen a lot of children sit down and eat a meal and be quiet. They're normally talking to each other within the process. And I'm like Dr. Harris, I have grandchildren within the school system here in Alabama, within Montgomery County, actually. So it is extremely important that we're watching and following through with what's happening with those meals. So everybody still needs to maintain as much of a distance that 6 feet is recommended. And if it becomes necessary for meals to be actually individual prepared or wrapped, so that some are eating in the classroom, some of them are eating outside, which actually reduces the risk of transmission because they now have the actual environment with the air and the other things that keeps them from being in that closed setting. So as many of those as we can spread out in order to increase that distance, the better off we all are. And hand washing and disinfectant is critical. Now, I've had people ask me about the face mask versus the face shield. Now, the face shield, I want you all to think about it. I meant to bring one. That thing is open on the bottom and it's open on the sides. Air, when you breathe in, think about it. It comes in from the directions and you breathe it out from those areas that's open. And that means anybody can breathe it in. Now, the actual Safer at Home allows the use of a face shield or a face mask. The reality is that a face shield is not As great as reducing transmission as a face mask is, it will provide you with some protection versus doing nothing at all. But if you really want to get the greatest amount of protection, you need to use a face mask. And even the type of face mask matters. You know, all things are not equal. A cloth covering with multiple layers, okay, is sure a whole lot better than doing nothing at all. And it has been shown to reduce transmission to the person who actually has it on, and also reduce the particles that get out for a person that they may be talking to or around. So it is extremely important to do that. You know, surgical masks, we still try to get people to leave N95s for healthcare providers. There are KN95s, which is the Chinese version, but also manufactured some now in the U.S. that doesn't have quite the high a standard as the KN95, the N95, in reducing the actual particles that can be inhaled or exhaled. But it is really being now more actually recommended for people that are high risk, like the people that have the underlying comorbidities and other issues that they may want to get more protection than they would with just wearing a regular face covering. And you can actually get access to those KN95s now if you're not a healthcare provider. So that's a great thing in order to increase protection. So those are the specific areas with that. So when we get down to major symptoms, one of them means that that child gets sent home. Anyone in the class that's close contacts gets sent home. The report card needs to be completed. Even if there are two of the minors, what we've tried to do is work to not get those children out of school, but for them to still be sent home, but not the other ones that are close contacts with them, only for the major ones. And those children to be told, at least the parents, that they need to talk to their healthcare providers as soon as possible. Because the physician may say, well, this is something that I need to go ahead and test them for. And then based on the results of that is the physician's responsibility to complete the report card if they now identify that they are potential or a confirmed case of COVID-19. So it takes that responsibility away from the school and the teachers and the school nurses to having to do it. It puts it back on the medical provider, because so many people can have those minor symptoms. And it means that you're not having to frequently complete a report card for somebody with a runny nose or congestion. Okay? And I've covered the social distancing, 6 feet or more, even greater if you're doing stuff like shouting, singing. 6 feet is not enough, okay? Face coverings, they're not all equal. Face shields, better than nothing, but certainly not as protective as having on a face mask or a facial covering out of cloth. Seating charts in classroom and buses, we don't need you to send them to us, but we need you to keep them, because it'll help in completing the log when you're trying to figure out, well, who is close to which person. You know, was Mary Ann next to, Jane, or, whoever that person is. It's really hard to remember those things, so it's better to have some way to be able to refer back. Student movement within the school. We really need to keep everybody from being out in the hallway at the same time and making changes. They need to be basically phased, and so that one class is coming out and not everybody coming out at the same time and being in the hallway all at one time. And even when they're going to lunch or wherever else, it needs to be done the same way. Limit the numbers. Well, this one, I'm going quicker. I'm going on. So when it comes down to meals, we've already handled there are a number of ways to do it. But the most important thing is to limit the number of people that are there and sitting together in the cafeteria. Do it some in the classroom, some outside, some in the cafeteria, but spread them out. Hand washing is important for this to be done for at least 20 seconds. They can sing the song, happy birthday song, and get the verses of that to help them to remember with it. And then when the hand washing isn't possible, then the use of the hand sanitizers. But anytime the hands are visibly soiled, they need to be washed, okay? And cleaning and disinfecting, I know it's hard to get like the wipes, the disinfectant wipes, but they are really extremely important to have on hand to try to use. But if you can't, there are instructions in the guidance that's been provided with the disinfectant on how to create your own kind of solutions to be able to do that, and it also applies within the schools. And that's extremely important. Hopefully the housekeeping, janitorial staff have been actually had information explained to them, and they reviewed the documents that were within the toolkit so that they know exactly how to handle that cleaning and disinfecting. But I do a lot of that stuff even here at the office on my own. I have Lysol spray, I have the actual wipes, and I do the door handles to my office, I do the light switches. If I have people come in that sit at the table and then they get up and someone else is coming in between me allowing another group in, I disinfect the tabletop because other people have been there and I don't want to expose anyone else to that infection.
Thank you, Dr. McIntyre. I thought that was an excellent presentation, and you're always a difficult act to follow when it comes to this. We're going to talk a little bit about some of the new pages in the toolkit, but one thing that I would like to do just briefly is to put COVID-19 in a pediatric context for all of us that are very, very concerned about the situation with children coming back to school. Now, I do want to say up front that I'm not discounting adults, but I am a pediatrician, and of course that is the focus of what I wanted to talk about today. Again, I am not minimizing the healthcare risk of adults, but I do want to focus this to the school nurses primarily as this relates to children, although the symptomatology for adults is essentially very similar, so that if kids are going home for something, teachers need to go home for the same thing. So let's talk for just a minute about the incidence of COVID-19 in children. And one thing that we do know, when we're looking at national literature and also internationally, it does appear that probably about 7% or so of COVID-19 cases currently are occurring in children between the ages of 5 and 17. Now, if you look at some information that the American Academy of Pediatrics put out a couple of weeks ago, actually overestimated Alabama's cases, because at that time we had an age range of 5 to 24 on our dashboard, but we have since reduced that to the 5 to 17. I think that's been most useful. And in Alabama, we're running about that 7% in that age group. And again, that is numbers of cases that we have seen while school has been out this summer. And so we do want to follow and see what that will do during the fall and winter session. And also just a caution, that could represent the possibility that fewer kids have been tested because fewer kids have been sick during the summer, as normally kids are less sick during the summer, and also perhaps less access to testing, as testing was previously more difficult to obtain in the state of Alabama. So let's talk about those cases overall. If we look at that percentage, many people have asked me about hospitalizations in children, and we are going to be looking at some more data on our dashboard, hopefully related to hospitalizations. But to put in context that of the hospitalizations that we've had in Alabama, we've probably had 100 or so kids hospitalized. So that's still a pretty good sized number when you consider, pediatric cases, maybe 100 or so, and maybe a little more than that, but that's what we see in our AIMS data. And of that number of children, about 20% of kids who have been hospitalized, and again, I'm talking about kids who have actually been hospitalized, have required intensive care. If you look at the national data on that with CDC, it was probably about 30% nationally, so I think we're similar. I mean, I know that looks like a large percentage difference, but I think if we drill down into the data, it's not going to be dissimilar. That did consider some states such as New York who had extremely large numbers. Certainly, if we look at ventilatory support, people are very concerned. I mean, what is my child's prognosis if my child gets COVID-19? Well, we know that most cases are mild to moderate cases. And if you look at the kids that were actually hospitalized and required ICU care, probably about 6% of those required ventilatory care. Now, these were, in some instances, kids who had underlying health problems. So we do want to be aware that underlying health problems can be as much of an issue in pediatrics as it can be in adults. I want to mention infectivity. I don't want to spend too much time on the background, but I think we need to, as I said, put this in context. If we talk about infectivity of SARS-CoV-2, now I've had some people say, well, is it possible that kids get infected less than adults? Well, the answer is we're not sure. We do know that the ACE2 enzyme is probably less expressed in younger children than in older children, and that really in the nasal mucosa is probably where we look at where the SARS-CoV-2 really attacks, and really that spike protein gets involved in invading the alveolar cells, if you will. And so that certainly can be, if children have less expression of ACE2, then they may be less likely to become infected. Again, we don't know for sure. And recently there was a study that indicated that the viral load in the upper respiratory tract of children could be as high or higher than adults. So I think the answer is that we still have more research to do, and all this just gives us information to help us to understand that perhaps children in younger age groups might be less likely to spread COVID-19, or they might not. But clearly we do know that children in older age groups, probably 10 or 11 years of age, are equally as likely to transmit COVID-19 as adults. And Dr. McIntyre mentioned activities such as singing, and I'd certainly like to throw band in as another possibility for that. Now, I want to mention transmission just real briefly because people ask about transmission over and over and over. If there's been one thing that has been a constant in COVID-19, and I usually say they change the recommendations during the time that I'm doing a presentation, so I expect something will be new by the time we get off the podium. But we do have a lot of indicators that COVID-19 remains droplet spread, respiratory droplet, person to person. Contaminated surfaces can play a role. However, as Dr. McIntyre mentioned, if we keep the surfaces clean, and also if we're not touching our mouth, touching our nose, touching our eyes, and believe me, a mask will do wonders for that, then certainly we can see how we can reduce transmission, but primarily respiratory droplet, person to person. And the incubation period, and this is something I want to steal Dr. Mack's thunder just a little bit on, is talking about the incubation period. We do know the incubation period in SARS-CoV-2 is 2 to 14 days, and the average being around 6 days. And again, that's repeated in a lot of literature. However, when we say the incubation period is 2 to 14 days, we mean 14 days, because there have been cases reported at 14 days, and Dr. Mack, I read of a case reported at 24. So we have to remember that when we're talking about the incubation period for a contact, it is up to 14 days. And in order to ensure that we continue to keep the most up-to-date scientific information, I spend a lot of time talking to my pediatric colleagues, and also I'm very fortunate to be able to access information directly from two of the most eminent pediatric infectious disease physicians in the state of Alabama. And the other day I actually talked to them about the 14 days, because a lot of people are concerned about that 14 days of home quarantine for contacts. And both of them reaffirmed to me that at this time they believe the 14 days is appropriate and accurate and what we should be doing in Alabama. So that's not something that Dr. McIntyre and I dreamed up. It's not something that Dr. Harris dreamed up, but rather it is backed up by a pediatric infectious disease specialist. Now that it could change at some point, but it hasn't changed yet. So since it hasn't changed, that's what we need to do right now. So let's talk about symptomatology for a minute before I go on to discuss some of the forms. Now, when SARS-CoV-2 first came along and COVID-19 first came along, as a pediatrician, looking at these symptoms and then seeing a broader range of symptoms, This probably accounted, this symptom panel, with the exception of loss of taste and smell, probably accounted for about 80% of what I've seen in my pediatric career. So, and I've been a pediatrician for a very long time. And so this really made me think, well, goodness, how are we ever going to tease this out? And one thing I want to mention is school nurses, first of all, LaBrenda, just see you out there in the audience. I just want to say I'm glad I'm not one of you right now, because I think you all have a really, really tough job in front of you. But I want to say that I'm with you, and that if you need consultation or discussion, I know that many pediatricians in Alabama have already stepped up and said we want to help and provide information, and certainly I want to help the school nurses too. So that's why we're talking about this today. And a lot of school nurses have said to me, well, I just feel like it's my responsibility to keep COVID-19 out of the school. Well, let me make it a little easier for you. You really can't keep COVID-19 out of the school because you've already got COVID-19, because there is asymptomatic spread of COVID-19. And I looked at a meta-analysis this weekend. It was the best research that I've really looked at so far, that said probably about 16% of pediatric cases are asymptomatic. Okay, now I've seen a range of even higher with adults, but this one particular study that had just been published mentioned that. So really, you can't keep COVID-19 out of the school. I mean, you can do all you can to prevent the spread, but with even that level of asymptomatic, we can't put that on our school nurses and say if we get a case of COVID-19, it's the school nurse's fault, because it's not. It's not. So, you can't keep it out. I think the second thing we need to talk about is something that school nurses have said to me. Is like, well, I feel like that I must make sure that any kid that has symptoms of COVID-19, that, I must make sure that either I do what's right, I send them home, or I'll be blamed because they had SARS-CoV-2. Well, let's look at the symptom panel. If you look at the symptoms, what you see is, again, in different literature, but this specific meta-analysis that I was impressed with indicated that probably about 40% or so of kids will have the new onset cough. Probably about 40 to 50% of kids will have fever at some point. Well, how many other pediatric illnesses have fever? A lot, a whole lot. Again, I would have been unemployed if kids had not had fever during my career. So again, fever is common. It's common with lots of things. But let's talk about new loss of taste or smell. This is so uncommon in pediatrics that if you have new loss of taste or smell in children, younger children, middle school kids, whatever, and even high school kids, it's so unusual that I would say take that one to the bank. They probably got COVID-19. I actually had a kid, and Carolyn knows about this. I had a kid that I called. I have a caseload of the uninsured, underinsured, or people that don't declare a doctor at the Alabama Department of Public Health testing sites. Had a child that the only symptom the child had was new loss of taste and smell. The child also actually had new onset diabetes at the same time. So, that quite honestly was extremely and equally alarming to me. But again, that's really, when you're looking at the major symptomatology, you're really looking at cough, you're looking at new loss of taste and smell. I think these are really, really important symptoms that we're looking at. And in addition to that, looking at shortness of breath. Well, shortness of breath can occur with asthma, but if we don't know that that child has an underlying problem, and even if they do have an underlying problem, we need to take that, as a serious symptom. So that's why these were categorized for case definition purposes as major symptoms. That doesn't mean the other symptoms are not important. They are equally important in terms of pediatrics, but when we're talking about epidemiology, we're really talking about the symptoms that are requiring us to go ahead and investigate this and do a collection of material through the report card and basically consider this to be a more likely case of COVID-19. Now, the other symptoms we talked about, as I said, they're certainly not minor. If you have them, they're not minor at all. But in looking at some of the data on this, I saw where, headache and sore throat and myalgias, and again, all of these things can go along with influenza. They can go along with strep throat. they're probably seen in about 10 or 12% of COVID-19 cases. Now, if you look at the other symptomatology, then headache, again, probably about 10% or so of cases. And then we have to have a little bit of awareness and caution about runny nose. Just runny nose in and of itself is probably not going to likely be a symptom of COVID-19 without another associated symptom. Gastrointestinal symptoms have been kind of interesting because they also have been seen probably in 10 or 12% of cases, and there's actually a pediatric literature case reported of a child that had intussusception, a younger child with gastrointestinal. So I think you can see anything when you look at these symptoms, but what we're really talking about here is not putting an undue burden on the school nurses. I mean, my goodness, they already have enough to do, but to make people aware that, again, asymptomatic cases are going to occur, and cases that have the major symptomatology probably represent our best opportunity to identify a COVID and go ahead and do a case investigation and a contact tracing. And then with the other symptomatology, again, as Dr. Mack said, you're going to send them home. If you were going to send them home before COVID, send them home now. I mean, same thing, still send those kids home, and they should be assessed by their pediatric provider or their family physician. And I will have to say the Alabama chapter of the American Academy of Pediatrics, as well as the Alabama Academy of Family Physicians, has looked at a lot of material and tried to work very closely together in order to provide clinicians guidance, because when this kid comes to the physician's office, the nurse practitioner, the urgent care, they need to look at how they're going to screen those kids, and does the kid have COVID or does the kid not have COVID? So again, I think we've talked about that, and also I have to throw in, everybody knows I have to throw in the meta-analysis or something like that to impress Dr. Harris, but he walked out when I was discussing ACE2 receptors, so I won't really get into that. Let me move on in the interest of time and talk about the new materials that we have so that everyone can, I think that was the case study. Carolyn, did you want me to do the new materials first? Yeah. Okay. So I want to talk about the new materials first, just real briefly. And again, just to mention that if you look on page 9 of the toolkit, this really provides a step-by-step approach, if you will, reminding that, first of all, if we have a child that has major symptomatology, go ahead and put that child in the pre-identified isolation area. And then be aware that if we get a positive child, if we are, the kids shouldn't be coming to school if they're under assessment for COVID-19, but I'm sure it might happen at some point. But if we find out the child's positive while at school, or if we have a teacher that tested positive, again, they shouldn't be at school while they're being assessed for COVID-19, but it does happen, then certainly we want to isolate those children away from the other children and take appropriate action. Certainly, if people are positive, if they're COVID-19, they're going to be in home isolation for 10 days, including 1 day with no fever. Okay, so again, that's 10 days, and that's just the way it is. And if they are a contact, 14 days, Dr. Landers didn't say it, the pediatric infectious disease doctor said it. Well, Dr. Landers said it, but she borrowed it from somebody else. When we're talking about symptomatic people, again, go back and look at the information we talk about regarding major and minor symptoms in terms of reportability to the Alabama Department of Public Health. Now, if children have major symptoms, then we're going to identify the close contacts. And what is a close contact? Close contact, 6 feet or less, 15 minutes or more. The 15 minutes can be cumulative, but it's important for us to keep that distance if at all possible, so we don't have to worry about a cumulative. Dr. Mack is not my contact. We checked that out earlier today. Dr. Harris, you're not my contact either, and none of you people in the audience are my contacts. So just be aware what are contacts. Now, we do know that people will be likely in closer proximity from time to time, but if we minimize the contacts, then we minimize the problems that we have to take care of. So once we've identified a case, if there is a case reported to the school, go ahead and report that child to us. on the report card, even if their doctor may have already reported it. Redundant communication is never bad. Identify the contacts to those kids. We'll talk about the report card in just a minute. Report to the ADPH on the report card, and the school will follow its own procedures regarding notifying parents about a case of COVID in the school. We do have to remember that confidentiality and privacy are extremely important here, and also to be very, very aware that, again, I use my analogy of Classroom 1 and Classroom 22. If Classroom 1 has a case of COVID and Classroom 1 has not been interacting with Classroom 22, then Classroom 22 is not part of the investigation. So just be aware, but I do think in this day and age, it's going to get on Facebook and everybody wants to talk about it. But we need to step back and respect the privacy and confidentiality of individuals in a situation that we are dealing with. Now, this has been asked before, and so I'm going to remind again, of course, cleaning and disinfection I won't go into. That's already been discussed, and there's information in the toolkit. But the Alabama Department of Public Health will investigate the contacts, will investigate the case, will investigate the contacts, and will provide the guidance so that once a person is identified as a contact, they will be advised by the Alabama Department of Public Health how long they remain in home isolation. As I said, the 10 days with 1 day with no fever, and also the improvement of symptoms. If you look at pediatric course, for the most part, kids are going to run fever maybe 1 to 3 days. There have been some kids up to 5 days running fever. Most children are vastly improved by about the 6th or 7th day of their illness, if not before. And again, that's from some of the articles that I have read. Now, in terms of contact tracing, same thing. We will identify the contacts in conjunction with the school nurses, and they will be in home quarantine, as I said, 14 days, and that's just the way it is. You cannot test your way out of quarantine. Doesn't matter how well you feel in quarantine, you're in the quarantine for 14 days. Now, as far as I've had many questions from the media, and I get lots of questions from the media. People say that they don't like to see me on TV, so I tell people to turn the TV off because I spend more time on TV than I want to. But the reality of the discussion about who reports cases is physicians are supposed to report to us. Schools are also to report to us. So we're going to find out one way or the other. We're going to get a lab report, but again, if we report redundantly, we're really okay. The school student screening tool that is in the kit is on page 11, and I will not read the form to you except to provide information. It's basically a yes, no. And the first thing that we want to be aware of on this is we're talking about contacts of a case of COVID. Okay, what would we do? Well, I've already told you what we would do as far as contacts. If the student has major symptoms, what would we do? Well, we've already talked about that, and I will go over the algorithm in just a minute. If a child has been diagnosed with COVID, that child will remain at home in isolation. And then there's guidance for returning to school. And again, the children who have COVID will be out for the period of 10 days, including no fever and improvement in symptoms. Contacts will be quarantined for 14 days. There may be kids who have an alternative diagnosis by their physician. They have symptomatology, but they wind up having an alternative diagnosis. And those, of course, will be individualized based upon the alternative diagnosis. I do want to caution that if persons are in the major symptomatology category and they test negative for COVID, a lot depends on when they were tested for COVID. Certainly earlier on in the course, you're more likely to get a higher likelihood of positive test because of the viral load. So if you have a child that has very compatible symptoms with COVID, but they test negative, really it's incumbent upon the clinician to reconsider that diagnosis because the child could test negative and still have COVID-19. There's a lot of information related to the rapid testing and some of the information from CDC. And just to be aware that rapid testing obviously is less sensitive than the PCR, but it still has merit and still is useful in testing for SARS-CoV-2. The report card, when to use the report card, I just have a couple more things we want to go through here, but when to use the report card on page 12, I think will be one of the most important pages for the school nurses to look at. And that also identifies, as I said, the major symptoms, and we're talking about major in terms of epidemiology for us to go ahead and open an investigation. Certainly, there are going to be kids that have minor symptoms that turn out to have COVID-19. But if we have a child that has at least one major symptom, at least one of the major symptoms, such as new onset cough, shortness of breath, loss of taste or smell, it doesn't have to be both. Now, what I've seen for the most part is that people have both, but it doesn't have to be both. It could be either or. Then those kids need to go ahead and be isolated. They need to get a pickup from school. They need to go home. They need to be evaluated by their healthcare provider, and their contacts need to go home too. And this is where we will have a provisional quarantine order for those patients, because I think it's really important for people to know, that this is what we're doing in terms of potentially having these kids out as a case of COVID-19. So those contacts do go home. If we have a child that has two minor symptoms, and again, we're not talking about the symptoms in and of themselves being minor, but just using that terminology in terms of case definition, if a child has two minor symptoms, they may have one minor symptom and go home because they've got fever, and that is perfectly fine. We're not telling anybody to stay at school with fever. We're not telling anybody to stay at school if they have vomiting. That's only one symptom, but we're not saying to stay at school for that. We're just saying in terms of COVID-19 investigation. But at least two minor symptoms, certainly that child also is going to go home and be assessed by their healthcare provider. And what I say in terms of contacts is, well, let's know where that kid was. With the two minor symptoms, we're not going to send the kids home that have contacts in that category, but we're going to want to know where they are, because they certainly could turn out to be a COVID-19. And again, this algorithm also identifies the laboratory confirmed cases of COVID-19. If we have a laboratory confirmed case, then we already know what to do and follow your algorithm. And again, I'll be happy to answer any questions on the algorithm as we move forward. So let's talk about the report card just for a minute. The report card, we have the contact tracing log. Again, for the persons who are sent home with major symptoms, send the contacts home too. We want to know who those contacts are and where those contacts are, because that will help us go ahead and launch an investigation. So the contact tracing log is in here. And then finally, the parent checklist, and I'm sure that there will probably be some upset parents, so I guess Dr. Harris wants them to call me. I assume that's probably going to be my other job. And I don't mind, because I want to work in context of what I'm trying to do as a pediatrician and also a public health officer. But the parent checklist, okay, your child was sent home. Why was your child sent home? This is why your child was sent home. They either had symptoms of shortness of breath or difficulty breathing, new cough, lost taste, smell, okay. Child's had the symptoms. This is what needs to happen. You've got your checklist here. And of course, if they receive an alternative diagnosis, then, we can certainly work with that particular issue. Same thing as there is a contact section here. And let me remind, I know Dr. McIntyre is going to say it again, but I have to remind, can't test your way out of quarantine. If you are a contact of a case, then you cannot test your way out of quarantine. So again, the parent checklist is just basically available. It's on page 14, and I think it's very self-explanatory. We talk about the provisional isolation and quarantine guidance, and that is going to be updated later this week. So there is a blank sheet, well, not really a blank sheet, but a title sheet in the toolkit, which I think is going to be very useful. And this is also useful from the standpoint of parents knowing what the instructions are, because we have had people that had symptoms and they went to the testing site and they got a specimen collected, and then they went on to work, and 3 or 4 days later they found out they had COVID-19. So in that period of time when they were probably most infectious, they were exposing everybody to COVID-19. So that's why we have made the requirement for, or at least the recommendation, I guess we would say, that what's a requirement in my book, if you're a suspect for COVID-19, you need to stay at home until such time as you have had disposition. And then finally, we're mentioning the report card. The report card, again, is very useful to us because this allows us the information not only on the suspect case, again, in talking about the child with the major symptoms, but also the contacts of that child. So we will be able to launch an investigation and rapidly get the disposition on this particular child and his or her contacts in order to reduce the spread of COVID-19. So again, I think the most important aspect of this is to remind everyone that we can't really screen our way out of COVID-19. Okay, we can do the best we can with symptomatology, with parents screening their children before they come to school every morning, with the school nurse screening kids home if they have symptoms, but recognizing that there are going to be cases in spite of the best we can do. So that really brings us to still continuing the measures that I always say people can recite better than I can, but that is the social distancing, the respiratory hygiene, and the use of the cloth face covering. Now, I don't think we can minimize any of that, and just to follow up on what Dr. McIntyre has said, and this has been asked many times of me, well, I was wearing my cloth face covering, but I was still close to people. You really have to use all three elements there, all three components, and if you don't use all three components, then you're increasing your risk. You're just increasing your risk of contracting the disease. So I think that's really where we have to look at this, is it's really all three of the elements together, practiced consistently. Now, Carolyn, let's see. Case study. You want me to do that, or you want Dr. Mack to do it?
I think that both of you can take a case and talk about it.
All right. Well, you want me to start with the first one then? Okay. All right. When we're talking about the staff or the student with one of the major symptoms, new cough, shortness of breath, difficulty breathing, new loss of taste or smell, what should the school nurse do? Okay. They have one of the major symptoms. School nurse is going to send that child home. She's going to provide the information as far as the checklist to the parent, provide information to the parents, the close contacts are the kids that are 6 feet or less, 15 minutes or more, can be cumulative. Should students and close contacts be reported on the report card? Yes, they should be reported on the report card. This is the major symptomatology. So, Dr. Mack.
I'm just going to make one comment. We have a lot of people that have joined us today, and they're trying to download the new Toolkit, so please be patient. I'm hearing from many of you that you're having a hard time downloading it, but I think we have a lot of people trying to download it. The other thing that I was just asked, just to sort of change up a little bit, is what about temperature checks? Should the schools continue to do temperature checks?
I want to
Lynn?
take that one. If again, I like to share with Dr. Mack here. There's enough for both of us to share. I think something that was really, really good in some pediatric literature that I read just over the last week or so is reminding that, especially in children, obviously, temperature can vary, so that having schools to take on the responsibility of temperature checking children every day when they come to school really puts an undue burden on the school or the school nurse, and actually could be a situation where, given the resources of the school, you can, first of all, dilute the resources, but also be in a situation where you have a lot of people jammed up waiting to have temperatures taken. So in terms of checking temperatures every day at school, that has not really been something that's been recommended in the pediatric literature. I know early on there was a lot of discussion about it, and I'm still not saying that parents don't need to maybe assess their child every day and, check the temperature before they go to school. That's perfectly fine with me as a pediatrician. But in terms of the schools doing that, I think that places an undue burden on the school nurses. And again, the literature is not really recommending that. Dr. Mack, you want to take the next one?
Yes, the case study 2 talks about staff and student is only experiencing one of the minor symptoms. And remember, we talked about the minor symptoms are things that are so that occur so frequently with other conditions that it's really difficult and stuff if you would take one minor symptom and then try to fill out a report card. Just think about congestion and the runny nose that a lot of children have, especially the younger ones, for most of the year, a lot of the time. So the recommendation is if they have minor symptoms and it is a symptom that you would have sent them home for anyway, like nausea, vomiting, diarrhea. Nobody keeps a child at school when they, in the what I call before pre-COVID-19, when they had those symptoms, they would have gotten them and put them away from other children and call the parents or the guardian and somebody to come pick them up. You need to continue to do that. No, the nurse does not need to fill out the ADPH COVID-19 report card. But if those children have those symptoms, and especially two of them, that form that Karen just talked about needs to be completed, and the parents need to know that they need to get their child assessed, because if they have two or more of the minors, they could have COVID-19. But this isn't something we want the nurses to do with one minor symptom. Karen?
Okay, and I think Dr. Mack really almost already answered this one, but I'll follow up again just to be sure. And again, that's the thing we have to remember. We have to reinforce this, because it's not that clear. It's not that clear in terms of clinical symptomatology. So we're just having to look at this and reinforce that this is what we're doing at this point in time. Recommending, again, staff student has two minor symptoms. What step must be taken by the school nurse? Well, as we talked about earlier, the symptoms, whether it's one minor symptom or two minor symptoms, the child still needs to go home if you would have sent them home before now. But if there are two minor symptoms, we need the school nurse to send that child home, make the parents aware that that child is needing to go home, and this child needs to be assessed by their healthcare provider, because they certainly could potentially have COVID-19. Again, the advantage of having talked to, and I think I've talked to thousands of patients by now, and probably about 10% of the patients I've talked to have been unattached children, if you will, the parents of unattached children, and just being aware that the symptom range can be broad. So it's very important that those children be assessed by their healthcare provider. What should happen to close contacts? And I like to say at this time, because at this time this is what's happening until we get off the podium today and something changes in the literature. But what should happen to close contacts? Well, that's it. I want to know where they are, basically. I want to know if they're in classroom 1 or classroom 22. You don't have to make a list, but school nurses need to be situationally aware, which they already are. And those close contacts at this point can remain at school. But we need to be aware that this child has gone home with symptomatology and needs to follow up with his or her healthcare provider. Okay. Dr. Mack, here you go.
Number 4, staff student exposed to a positive COVID-19 family member or close contact. So the school nurse receives a call, and let's say that there's a family member within the home that has COVID-19, that they're positive. This child, just by that situation, is now a close contact. Let's say it's their mom, it could be another sibling that's positive. They're within a situation where they are considered to be what we call 615ers. That means that they've spent at least 15 minutes or more within the presence of a person that's confirmed positive, closer than 6 feet apart, because you know that within that home situation they've been interacting, whether they've been brought to school, eating, whatever that is with that process. So when that occurs, that child is not to be allowed back within the school. If you determine that they were already in the school, make sure that they are determine that they don't have symptoms when they're getting ready to be sent home. And then a contact of a contact is not a contact, okay? We get asked this all the time. They want to send the child is a contact, which means that they are a 615er. But persons within their classroom, unless that child is symptomatic, which is why you're asking whether they have the major symptoms, because let's say you got the notification and little Jimmy, when you started asking questions, you pull them out, isolate them as soon as you can, and you start asking questions, and guess what? That child has one of the major symptoms. then that means that anyone that was in contact now with that child, because they're no longer just a contact to a contact, they're a contact to a potential COVID-19 positive person, then they need to be sent home. So it really depends on what the situation is of little Jimmy. Is little Jimmy just a close contact with no evidence of symptoms, even though we've talked about asymptomatic children? What you're operating on is the information that you have available. And the report card for that child, based on being a 615 or asymptomatic, would be completed.
Save that one for Dr. Mack because that's one of her favorite topics. So, okay.
All right.
Dr. Mack, I think we're back to you.
It's me again.
You.
Okay, this is something I know you all have been struggling with. And I tell people it's really not hard. So we're going to go into some stuff to make this easier. This is pages, you're going to look at pages 19 to 24 when you're looking within the new toolkit. And it starts with the quarantine and isolation guidelines. We also have a one-pager available on the ADPH website that's also included as page number 22 within the toolkit. So page 22 within the toolkit contains that one pager that we utilize with our staff to determine what needs to happen with a person for quarantine and isolation. We do have coming out a quarantine order that would be a standing quarantine order, that provisional that will allow people to put something in a person's hand that is identified to be a potential case, or even a person getting tested done because they're symptomatic, so that they understand that they need to stay home. So I'm going to go through this one by one. So when we're looking at quarantine and isolation and what we need to do, Karen's already covered that with one minor symptom, you are not sending the classmates home or the teacher home because they were in contact with that person. Not immediately. But what may happen is when that child gets out and is identified based on medical assessment and has to be tested, and that test ends up coming back being positive, then it changes the whole situation. So that now the teacher and the classmates, which is why the nurse needs to be situationally aware, it flips it to now those persons having to go home under quarantine. Okay, and that's when that provisional quarantine order also comes into play. It gets handed to them because they are now a close contact, a 615er. Okay, if they did not stay the distance, they did not have on their face coverings, they did not do the stuff that comes into the face covering, really, and I'll go back to that, but even with the face covering, it's just to protect them. So it's not really the ingredient, it's the time frame, and also making sure that they're doing what they need to do from the standpoint of the total amount of time with that distance. So if that's 15 minutes or more, and it could be 5 minutes plus 10 minutes, or it could be 5, 5, 5, or they could have done that 15 minutes all at one time within that day at school. And as long as that 15 minutes is cumulative, or it could be a single time frame of 15 minutes, and they were within the 6 feet, which meant that, let's see, I was sitting over here next to Karen, instead of as far away as we are, then we wouldn't meet that requirement because we would not be at least 6 feet apart, okay?
Dr. Mack, can I just bring up something that we're getting a lot of questions about? You both are masked. So the question is, if you're closer but you're still masked, why wear a mask at all?
I wear a mask because I don't want to be sick, okay? All right, it's not a matter whether or not I get sent home as a contact. The whole idea behind this is to reduce the risk of transmission. So let's say that I decide I'm gonna get closer to Karen, okay? The fact that I have a mask on and I reduce that distance and I spend the next hour close to her does not make me not a close contact. I am now a close contact to her because I've got up in here, I got my mask on, we talking, okay? But the risk is not zero, okay? Even though it's better than not having a mask on, I still have a risk of transmitting the infection, and I don't want to be leaving people out there because I exposed them. Does that make sense? The mask keeps us from breathing. It helps limit the particles or the viral particles that we breathe out. And it also helps limit what comes in. But that does not mean that it's zero. Okay? Something can get through. It depends on what kind of face covering I have on. There's evidence now that there are some that are better than others. Those little things that you pull up, I don't even know what they're called, the neck things with those little gaiters with one layer, you might as well just not even bother to wear them. There's evidence coming out that shows that if you can blow a match out, with them, that means what? That air and all the other kind of stuff associated with it is coming out. So if I can blow a mask out with the thing on, that's a good test to see whether or not the mask I have on is doing any good at all. So it's extremely important. Major symptoms, any students with it and any close contacts to them need to be sent home. A close contact, we've talked about over and over ad nauseum. It doesn't matter whether I have a face covering on or not. If I stand up in your face and you get in mine with that face covering on, and we are a foot apart, 2 feet apart, okay, and we stand and have a conversation for 15 minutes or more, you're a close contact. That's it. Simple.
I think, and really just to follow up on what Dr. Mack has said, if you look at, there is a lot of information in the scientific literature, and some of it is very, very early, but I think that you're seeing more, especially after the MMWR came out a few weeks ago, that, originally the discussion was for face coverings to limit asymptomatic transmission. But there is starting to be, as Dr. Mack said, some indication that also it is reducing transmission from persons who potentially have disease. So it's working both ways. But I think if you look at the science on it, as we have said before, unless people are wearing an N95 particulate respirator, then there is still some risk coming through. And an N95, why is it called a 95 instead of 100? Well, because it is a 95%, not 100%. So I think we have to look at it in context of science, and also to use I have to use this analogy that my son-in-law, who's a former Marine, it just sticks in my mind when he was talking to me about face coverings and how important it is for the general public to think this way, is that, when you are in a situation like he was in, you had to wear your helmet and you had to carry your weapon and you had to wear your body armor. And if you went out of the tent with just 2 of the 3, you significantly increased your risk of having something bad to happen. And so, I obviously want to express great respect for our military, but also that just sticks in my head. It's like, okay, you're going out without all 3 pieces of the puzzle, all 3 pieces of protection. So think that way. But none of it is 100%.
That is correct. You increase you reduce the risk of transmission the more you do. Think of it that way, just like she said. The more you do as far as following the requirements, you get better. So I'm gonna put on my face mask face covering, because I want to not just protect myself, but also reduce the risk to others. Okay? Now, just because I'm gonna get closer to them, as long as I can maintain a distance, I'm gonna do that. But there may be a situation, let's say, where you cannot, for whatever reason that occurs. At least with having that protection on, you got at least part of the pieces where you combine and you're still doing them. But if you throw away a component, just like she said, if they step out and he steps out with just the gun and the other part on and not the helmet, then something could happen because a piece of that armor is missing, that protection is missing. Think of it the same way with the mask. So when we look specifically at looking at the guidelines, we always get asked, looking at the 10 days, and we're going to go through all of this. Why does a student or a staff member who's a close contact of a symptomatic or positive individual have to quarantine or isolate for 14 days? And it's really quarantine as long as they don't have symptoms. If they're not sick, it's a quarantine period. If the person is sick, they're infected, it's isolation. And the time frames differ. And this is where people say, well, why do I have to worry about 2 different time frames? I'm going to explain it, hopefully, so that people can understand it. A person who has been exposed to someone that is infected, okay, which means that I potentially breathe in some of that virus, or took my eye and rubbed my eye and from a surface and ended up inoculating myself so that I'm infected. But in order for the actual infection to occur, remember the virus has been introduced, but until it grows and replicates and divides, it has to get to a certain state before the person that it was introduced into, that's me, I'm the close contact, okay, actually shows evidence, or they may not ever show evidence of being symptomatic. They may be an asymptomatic infected person. But for them to actually go from exposure to infection, they have up to 14 days. Now, there's some evidence coming out now that in a small percentage of people, it may be even longer than that. But for the majority of folks that get exposed to somebody that has COVID-19, whether that person is asymptomatic that they're exposed to or showing obvious signs and symptoms of infection, that it can take up to 14 days. So when you go and that person is a close contact, runs to get a test, whether they get that test on day 2, day 5, day 7, and the test is negative, it means absolutely nothing.
Okay, we are getting a lot of questions for y'all. So it's about close contacts, once again, can't testing their way out of quarantine, which
That
is
is
a
correct.
statement. Okay, but if a close contact is negative and a physician writes a work excuse release to return before the quarantine is over, the school nurses are in a really bad
I understand
position
that.
because are they to accept that physician's order or deny that student staff to return to work or school? And they said, as nurses, we work from physician orders, and it trumps our procedures, is why this is so complicated.
We understand it's complicated. We tried to send on last Thursday, and it didn't get out until today. And we're going to work with the Medical Association and with the Alabama Board of Medical Examiners to get this same HON that just went out to go out by them. The reality is that a physician should not be writing an order or a return to work for somebody who is a close contact. You cannot test out or release yourself out of quarantine, okay? And just like I explained for them, this went out this morning, and what it says is it's a Alabama Emergency Response Technology Alert. It went out to all providers within the state, and it explains to them that it is important to instruct persons to isolate and quarantine at home while awaiting test results. But then it says it is important that any person who is a close contact to a COVID-19 case complete at least a 14-day quarantine period, even with a negative test. I don't know how to make it any clearer. This went out to all providers within the state. So we understand that you all don't want to get in the middle of it, but if we can at least know who some of those doctors are, we can work with trying to talk to them. But we will get this out within the next 24 hours through the Medical Association and potentially through the Alabama Board of Medical Examiners. Okay, all we can do is try to help you because, and us, because as long as we've got people coming out of quarantine, let's say that they had a negative test, okay, and the doctor gives them the release that they can return to work and it's day 7. And on day 9, they get all of these symptoms, they in the classroom with the students, or the student is back in the classroom. What happens? We've now got a whole nother group that's been exposed and potentially infected because the person did not stay under quarantine for 14 days. Now, there is an alternative where they can come out. Let's say that the person was not a close contact. Let's say that somebody went home because they had 2 minor symptoms, okay? And they went home and the doctor assessed them and determined that there was an alternative reason and diagnosis, okay, that explain the symptoms that they had. They are not close contacts to anybody that requires them to be isolated or quarantined. They can get an excuse for that and be sent home. Does that make sense? So close contact, I know I've been sitting next to Sally and Sally is infected, or I live in the house with Sally and Sally is infected. I cannot get an excuse to be tested out of quarantine. I cannot.
You know, Dr. Mack, I think one of the concerns sometimes is we all know that sometimes people don't get all the history, and that parents with the very best of intentions and want to do what's best for their child and for their family might go to a physician and provide information to the physician or the nurse practitioner and inadvertently not explain that their child was a contact to a case. So I think that's where, again, the parent with all good intention and not
Somebody
needing
talking to the physician to provide them with
that.
the info that's missing would be helpful.
And the physician not being aware or the nurse practitioner not being aware. So I think that's where we all work together. And if we have those kinds of situations, and I know LaBrenda's going to call me, and
That's
then
what I was saying.
when LaBrenda calls me, I'll deal with it. Because
And we'll deal with it, okay?
and we won't put the school nurses in that position because, again, my experience with physicians in the state of Alabama during this has been that people just want to do the right thing. They want to assess to the extent of their clinical ability. They want to test appropriately, and they want to ensure that isolation and quarantine is followed because they don't want to increase their workload any more than they have to. So I think it's a matter of everybody working together, but also reminding the school nurses that we don't need to put them in an awkward spot.
So if they provide us with the names, which was I was saying, we'll do what we can to make sure we're talking to the provider that they have the information they need so that they understand what the situation is, which is what also the provision of quarantine order will do. What do you
Well,
mean?
I wanted you to repeat that part where you say that there is a way to get out, like if they wasn't part
If
of
they're not a close contact,
Right.
okay, this is where the thing comes in, which is trying to get people to understand. If the person is a close contact known to someone that's COVID positive, you cannot test your way out of quarantine. It's as simple as that. That means that person meets that 615 criteria. They were within 6 feet for longer than 15 minutes. It doesn't matter what their test results come back showing. Okay? And this is what I tell people. I understand folks want to be tested, whether they're symptomatic or not, okay, if they were close contacts. We don't have any issue with it, but what we recommend is, first of all, if they're close contacts and they have no symptoms, they probably want to wait a few days to increase the possibility that the test will come back positive, even if they're asymptomatic, okay? But even if it's negative and it's day 10, they could still become infected and infect other people on day 14, okay? Which is why they do not need to get an excuse and go back to work. It's also why within their homes, they need to isolate as much as they can away from others. If they have to come out for whatever reason, if they can use a separate bathroom, if they can't, then they need to make sure they're doing cleaning and stuff before other people come in. They also need to have a face covering on when they come out to do stuff within their homes so that they're not exposing people within their homes, okay? Because otherwise it's ongoing. And let's say that we have that person that is in a home situation where somebody is positive. It can be longer than 14 days. Why? Okay, the mama, let's say whatever the mother is positive. We've identified that little Jimmy doesn't have any symptoms at all, but he has to go home. Now, if the mama is still out there cooking and she don't have a face covering on and she's putting little Jimmy in her lap and she talking to little Jimmy at the table, transmission is ongoing. The actual last day exposure is where the 14 days starts up. So as long as the exposure is ongoing and she does not stay out of the away from the rest of them. She's continuing to go where they are. Exposure is ongoing. So it does not stop until she comes off of isolation. So on day 10, beginning the next day, the quarantine can start. Which means that now it's been 10 days. If he got sent the very first day they found out, let's say that he got sent home day 3, because that's when everybody got the test results back of when her symptoms started, okay? Then he got sent home on day 3. She still has how many more days to go? She's got to get to 10 days, okay? On that very next day, his 14 days starts, okay? When she gets to day 11. When she gets to day 11, that's day 1 for him. Okay? So now he started, but he's already been out of school for over a week. Okay? But because the 14-day quarantine period does not begin until the isolation and stuff ends for the mom, he now has that 7 days plus 14 days that he has to be out. Okay? Which is where we're having the problems with getting everybody to understand. So now, that's the 14 days or more. Because it could go, because let's say there are multiple people in the house. And we have this domino effect. She gets sick, day 5, somebody else gets sick. Day 10, somebody else gets sick. They're not doing anything to limit exposure within the house. What happens? It becomes the last day of exposure of the last person who became ill. So it could be 15 days out, okay? When the other person ended up becoming infected, they still all been eating at the table, doing everything else together. So now I got to wait until this person gets to their day 10 so that I can start that. So guess what? Little Jimmy now is out 21 plus 14, and it can go on, okay? Which is why it's so important that folks isolate themselves if they're sick within the home, okay? Because that could turn into, a long time if we got a whole lot of people in multi-generational within a home. Right. So isolation, why 10 days? Now remember, for quarantine, the person is not sick that we send home. They've been exposed to someone that was infected, and there's an incubation period that we're waiting on before potentially that person becomes infected. That's the 14 days. A person who's already sick and infected, what we're looking at is the decrease in the viral load and the ability of it to be able to be transmitted to someone else. The 10 days comes from the fact that when, y'all, I'm gonna put this mess up. The 10 days comes from the fact that when the person has actually had they're sick, that virus eventually, when they're sick, it starts going down, the amount of it, the load. So it gets to a point where they can't give it to anybody else, which means that even if they're at the point that the virus is going down number, okay, that it cannot be reproduced, it can't reproduce, and it can't grow, okay, and therefore, even if they breathe and the virus is pretty much gone, there's nothing there, that's where the 10 days comes in, because the evidence is showing that the majority of folks by day 10 cannot transmit the virus to somebody else. If they have not had a fever for at least 24 hours and their symptoms have improved. Now, it does not apply for somebody who's still sick, still symptomatic, and especially if they have severe disease, because the more severe the disease, and especially if the person is immunocompromised, it's going to be longer than 10 days. So that person could potentially still infect somebody else past that 10-day period. But that's where the 10 days come from, because the majority of people who were sick cannot give it to anybody else.
Okay, so I'm getting a lot of questions still. So a question came up about rapid testing. I think this is such a different kind of virus. It's hard for people to really understand all of the ways this affects. And thank you for clarifying the 14 days as a close contact versus somebody who actually has COVID and the 10 days. All right, so this question is if a student is going for rapid testing due to symptoms, so we're going to rapid tests because of symptoms, is it okay to wait for the results or the diagnosis before putting the close contact exposures in quarantine?
Not if they're close contacts and the person had symptoms. No.
Okay.
That's the whole idea that we talked about, that if the person's had major symptoms, okay, and they have close contacts, the close contacts need to go home. Okay? Regardless of whether the test results or what they come back. Okay?
All right, and this one starts with a pediatrician, so I'm going to look at Dr. Landers for this one. A pediatrician has told one of our parents that their student does not have to quarantine for exposure to a positive case because her son already had COVID-19 in the past 3 months, and the pediatrician told him the parent that he's immune for 3 months. So will you talk about kids that have already had COVID and how we handle them?
Okay, and that's a very good question, Carolyn, and really something that I think CDC clarified fairly well in the last week or so. If a person has had COVID-19 and they've had it in less than 90 days, less than 90 days, and they're re-exposed, but it's been less than 90 days, and that person who has been exposed doesn't have any symptoms of COVID-19, then they're not placed in home quarantine. But that is less than 90 days.
Less than 90 days.
The CDC has recently indicated that, and we really don't know about COVID immunity, but we do have some indication that at that point in time, there could be the possibility of reinfection. So again, if it's been less than 90 days and there's a re-exposure, they don't have to home quarantine. But if it's been longer than the 90 days, then they do. And that came out, I think, a week or so ago.
Yeah, about a week ago.
In the CDC literature.
There's actually information today with what they believe is the first instance of documented reinfection from COVID-19, and it is past that 90-day time frame. What CDC says on their website is that at this time, there's no evidence of anybody becoming reinfected within a 90-day time frame. So they're making it really clear, and they say that if that person does become symptomatic again at less than 90 days, because we don't know, there is a potential, then they need to be tested and treated as if they're reinfected. But we have seen no evidence so far in the literature. The information is there today that's saying that in China, this person is at 4.5 months, that they may have evidence of reinfection. So that's still to be seen, but less than 90 days, they don't have to go back into quarantine.
Okay. And then there was a question, I had 2 questions about the 615 rule, that there's been rumors that it's been changed or that it can be changed.
I was on CDC's website before I came in here. It has not been changed. Okay, now, just like Karen said, it may change later, but it wasn't changed when I checked it at 12:30, okay? It still had the same definition for close contact, okay? It had the same definitions down as far as what the 14-day quarantine. This is what I've heard. Oh, the 14-day quarantine doesn't apply. I said, according to CDC and their frequently asked questions, it still applies. I verified that before I came in here this morning as well. It still says 14 days quarantine period for close contacts. Now, it can be longer, okay, and I already went through the examples. And you can also have a person who has to do isolation for more than 10 days. There's a recommendation for some people that are immunocompromised with severe illness for 20, okay? And the reason for that is because they can shed that virus longer and give it to other people who then can become infected.
And
They can hang on to it longer.
I think the distance situation came up. There has been some literature. The WHO has alluded to a shorter distance, and the American Academy of Pediatrics, of which I am a proud member at the national level, has alluded to a shorter distance. But what I always remind people, and the way I feel about distance, is if I say 6 feet, I'm probably guaranteed to get somewhere close to 6 feet. But if I say less than 6 feet, if I say 3 feet, then I'm probably only going to get 1 foot. So at least right now, I think the consensus among we in public health in the state of Alabama is to remain at the 6 feet until we have more clarity in terms of what really is appropriate. It may change. Again, it probably is changing while we're talking about it right now. But still, to stay with the 6 feet, I think most of us feel more comfortable with the 6 feet, although that certainly could change. But that's where we feel comfortable right now.
And remember what I said earlier, it needs to be increased based on what activities you're doing. So that if you're in a choir stand, okay, and you're singing and there is no mask on, or even if there is a mask on, 6 feet is not enough, okay? Which is what we've been trying to explain to people, that they need to spread out more, okay?
Okay,
Yes.
so
Carolyn.
Uh-huh.
Dr. Mack, I would like for you to speak to the school nurses when it comes down to those students that present with underlying condition. As you spoke, our asthmatic students, what other steps, in the face-to-face environment would we need to take to make sure that they are protected?
One of the things we talk about, if a child has underlying, and same thing goes to an adult that has underlying health issues that place them at a higher risk, and they've been close contacts to people, regardless of whether they have symptoms or not, you need to take additional care of them, so that we make recommendations for, even if they don't develop symptoms, to try to make sure that they don't have the infection because they were close contacts, that they probably need to go ahead and be tested, okay? That recommendation is somewhere around that 55 days because they're more likely to then show evidence of it. But they need to be watched because they can start out with no symptoms or be asymptomatic and still be infected and go downhill quickly. And Karen can answer more to that, but it's the same thing as with the adults, that we tell people with underlying health issues that if they've been exposed or the potential for exposure is there, they don't have to be symptomatic in order to get a test.
I think just to follow up on that, there's indication in some of the pediatric literature about children with immunosuppressive conditions, but also children with underlying problems that we think about, diabetes, sickle cell anemia, cardiac and pulmonary disease, but have we ever thought about obesity as an underlying health problem?
And it truly is.
So it is, and obesity does increase the morbidity in COVID-19. So we have some indication, especially in minority populations, that one of the reasons minority populations may have a higher incidence of being hospitalized as children and adolescents that are minorities is that they may have an underlying risk factor such as obesity. So, one thing that as we looked at contacts, we talked about you cannot test your way out of quarantine. However, I agree with Dr. Mack that if we have children that have underlying health problems, that I would, if they are contacts of a case, that I would test those kids somewhere around, a lot of people say don't test before 4 to 6 days. I just say 7. That way I think I
get them anyway.
the widest range there. So, but test them somewhere around the 6th to 7th day after exposure, because I think it's important. One thing that we as pediatricians are honed in on right now is, I think if you can test a contact that has a high-risk health problem, even if they're not symptomatic, then that gives you some information, because we truly do not know if everyone that has COVID-19 and recovers, whatever recovery means, might not have a problem down the road. And also the multi-system inflammatory syndrome of children, which is very rare, but again, something that we would want to be aware of. It is a serious condition. So in terms of underlying health problems, if they are contacts and there is the ability to test them as a contact, I'd go ahead and test them. They're still going to be in the home quarantine, but I would test them during that time frame, probably about 7 days.
You're trying to make sure by doing that because they are at such a high risk that if they're identified, even if they don't have symptoms and they're symptomatic, that's information the provider can use in making sure that everything is being done to prevent additional complications as much as possible, which is why we make the recommendations for high-risk adults as well. There's a question up here. If I'm a close contact with symptoms and I have a negative test, can I go back to school? No. Close contacts. Doesn't matter what the test shows, okay, if you are a close contact, what did we say? You cannot test out of quarantine. If I'm a close contact with no symptoms and have a negative test, can I go back to school? No. Close contact. Quarantine, you can't test out, okay?
Okay, we still are getting lots of questions, y'all. So this is a simpler, I'm going to take it off of quarantine just for a second. So should teachers be wearing masks instead of face shields? What would your recommendation?
Well, I think Dr. Mack addressed that already, but I'll go ahead and talk about it. And one thing that I like to do, and I think Dr. Mack and Dr. Harris both know this about me, is I like to read all the articles I can find and then some. And when I've read it, Dr. Mack's already read it or is sending me a copy of it. But the face shield information, there is not clear evidence about using face shields in COVID-19. Now, there is some information about using face shields in influenza, but we're not talking about influenza here. We're talking about SARS-CoV-2. The concern to me is there's not literature on it that supports it. But we will say that the Safer at Home order has allowed the use of the face shield. So my thought on it is that you will have people, and I'm going to quote some information that I have read, you will have people that for some valid health reason cannot wear a mask, okay? But I'd rather they wear a face shield than nothing at all, okay? But my preference is to the mask because we have some indication in SARS-CoV-2 about using the mask. We don't have indication about using the face shield, but if I were in a situation where I had a person that had a sensory processing issue, or I had someone who had some specific reason they felt like they could not wear a mask, even to the point of, feeling that they were anxious or smothering or something like that, I would rather they wear a face shield than nothing at all. The face shield does need to come down below the chin. It needs to cover the sides. And the face shield, if it is a reusable face shield versus disposable, it needs to be properly sanitized based upon the manufacturer's guidance for that particular plastic or type of plastic used.
CDC specifically has on their website that a face shield does not replace a face covering on their website. But I tell people that it, like Karen said, it's better than not using anything at all. But if you want to maximize your protection and the protection of others, a face covering is preferred by CDC, okay? If you have high-risk conditions that you're at a higher risk, then put them both together, which means you can enhance your protection by using the face covering with the face shield, okay, if you want to add to your protection.
Okay, I've got a question on the 615 rule. You mentioned the exposure time is cumulative. However, there are some educators being told it is not cumulative, but only when it is 15 consecutive minutes or more. So is this an area that is up to the school to decide which to follow?
No, and I actually went to CDC because we kept getting questioned, okay, as far as whether or not it was cumulative or whether it was a single exposure time. And CDC sent in writing in an email response that it can be a 15 minutes continuous, or it can be smaller instances within the same day that add up to 15. So I've got that in writing from the CDC.
You know, I think that question comes up about cumulative. We really need to be consistent with our distancing, and that's very important to, I mean, because obviously we're going to pass by the same person in Target sometimes. That's going to happen. Hopefully it's a brief
But it's 24
pass.
hours.
But again, just to say to try very, very hard to be consistent with your distancing, and don't do something that I heard on a presentation that a person had taken off their PPE, and then they realized they had to go back in the COVID unit, so they just ran in there real quick and ran back out. And that just doesn't get it, okay? So let's try to be consistent in our practices and to not put ourselves in those kinds of situations where we have to deal with cumulative. I think cumulative can be a bit of a problem in determining, but again, the consistency in maintaining the distancing
Then you don't
along
have
with
to worry
other
about the
factors.
15
Really don't have to
minutes.
worry about it. So.
If you're consistent in your distancing, then it doesn't matter, okay? That's what they need to remember.
Okay, here's an interesting question. What if a student is not tested that was sent home with symptoms? So you're sent home with, we're going to assume it's major symptoms.
Then they're out.
They're not tested. The close contacts still have to quarantine for 14 days, even though there is not a confirmed positive.
If it's major.
You know, the challenge there is going to happen sometimes in pediatrics. In the state of Alabama, I think we have to remember that while most kids should be covered by insurance or by, you know, the Medicaid program or the All Kids program, there are going to be some kids that don't qualify. And I think these are instances that when the school nurses encounter those kinds of cases, to try to work with their social workers or even the local health department to see if we can find a provider for that child to be able to be assessed, because if that child never has a test, then they have to be presumed
To be
a COVID. And so, and really,
They're out the whole 10 days.
my preference would be to try to get that kid tested. You know, that would be, and to try to get that child assessed. And, you know, I'm one of these, I think there's a question, and Dr. Mack may want to answer this too, but that, well, should I just take my child and get tested without talking to my healthcare provider? Well, really, as a pediatrician myself, and I think that Dr. Mack is an internist, we would always prefer that people have a physical assessment, at least talk to their doctor over the phone, whether it's a telemedicine type visit. I think a lot of people are doing more of that, but not just go and get your kid tested without checking with your healthcare provider. I think some of that's going to happen. But my preference would be to try to go through your medical home. Try to go through your medical home.
And it's actually up here on this slide. It talks about, should I take my child further without consulting my provider? We really prefer that you talk to your physician. Some people may not have a medical provider, and if that's the case, then that's why we have standing orders in order to get people that meet criteria that they can get testing done through the health departments. And then we have physicians that act instead to assist when those tests are positive. And this right here says, if I don't hear about my test after 7 days, what should I do? Well, if you're a close contact, you're gonna stay in quarantine anyway, okay? So the reality is, and I put down the answer to this, supply and demand. We all know that the higher the number of people that want to get tested, whether they're doing retesting because of employment, which we don't recommend, nor does the CDC, okay? They're not asked to go and get retested for that, but they're still doing it. And that in itself is increasing the amount of testing that has to be done within the system, what I call an unnecessary test that slows down the results that people really need for folks that are symptomatic that need the results in. And that's why it's taking so long. It's taking so long because the system cannot keep up with the demand, and we're having issues. We're getting reagents in to do the testing, so that's where it is, okay?
I do think it's important, and I have to give a little bit of a plug here for the next 12 days or so, that there is going to be an opportunity through 2 sites in Jefferson County. Some of you have probably already heard about that, but also a site in Tuscaloosa for specimen collection through HHS. And again, I remind people that that test is just a snapshot. It's just that one time, it's just a snapshot, but there is a free opportunity, and it doesn't have to be restricted to people that are in Jefferson or in Tuscaloosa. Persons can come from surrounding counties. So there's information on Jefferson's 2 sites. One is at the Galleria, the old Sears parking deck there. The other is at the Cathedral of the Cross in Center Point, and then the Fire and Rescue College in Tuscaloosa on Calusa Avenue. Just to say that that's opportunity there for a couple of weeks, and I think it's 12 days to be exact, and that's an opportunity for people that certainly, even if they don't have symptoms, to be tested. But there are going to be not only the test capability there for persons, but also this is self-swabbing. Anybody that's been reluctant to have a nasopharyngeal swab, I don't know why people are reluctant. I thought it was fine myself, but I've had it done, and not for COVID. I didn't think it was a problem, but just to be able to remind people that that is available, and certainly we'd like to encourage people to take advantage of that. The goal is to test about, I think, 5,000 total, maybe even in a day. I don't know that we're going to reach that with those 3 sites, but it would be great if we did. So.
Okay, we're getting close to where we're going to need to end, but before that, there's like 2 more slides. This is the isolation and quarantine timeframes for COVID-19. It is available on the website. It actually links to CDC information that supports the requirements within it. And because there's a link in the document, any changes that occur will also occur wherever the link is. So we simplified it. It used to be 5 or 6 pages. It's one single page where people can go to and actually pull that information, and it's also within your toolkit. And then the 3 steps that we need people to understand that they need to take while they're waiting for their COVID-19 test results: stay home. This is not the time for you to go to work. It's not the time for you to go shopping. Okay, we talked about quarantine. Stay at the house. If you got other people, especially high-risk folks, you really need to try to isolate as much as you can away from other people so that you're not putting other folks with the potential exposure. Think about the people you have recently been around so that when you do get a call, you can have the names and all of that stuff ready to give to the people with the Department of Public Health. So start doing that as soon as you go and you get your test done, okay? And I'm going to turn it over to...
Yeah, I just want to tell everybody, thank you so much for being here. I'm going to ask Dr. Harris to close out our session today, but I also just want to let people know I'm looking at all of these questions that we have not had an opportunity to answer yet. We will be posting questions and answers on our website, so please forgive us for not being able to get to everyone's questions. And I'm going to turn it over to Dr. Harris to sort of end the conference today. Thank you.
Thank you very much. Thank you, Carolyn, and thank you so much, Dr. McIntyre and Dr. Landers. That was a terrific job, and I really appreciate you taking the time to do this. This is, again, I'll say, truly an extraordinary time. We know you all are facing really unprecedented challenges and situations in your own schools, in your own districts, and we want to do our very best to be your partner and to help you find your way through this. We recognize that there are a lot of situations that we just couldn't cover because we can't even imagine them yet, but we know that over the next few weeks we're going to have all kinds of questions and issues that comes up, and we'll be here to help you navigate your way through that. So again, thank you for all that you do. Thank you for taking the time to join us, and hopefully we'll be speaking again with you soon. Goodbye.
Resources and website for updates. We will be posting updates there. And thank you again to our speakers. It was terrific. Thank you.